Okay, alpha-2s. This is a sedative hypnotic. So these drugs provide reliable sedation, maybe analgesia. The studies out there are a little bit conflicting, and muscle relaxation. So alpha-2 to alpha-1 receptor selectivity. So some of the older guys, so xylazine, then dotomidine, then romifidine, this is the alpha-2 to alpha-1 affinity for these two receptors. The reason why dexmedetomidine came out was because they wanted a really high affinity for the alpha-2 receptor to the alpha-1 receptor, because the alpha-1 receptor is associated with all of those adverse effects that we see when we used to give, or some people still, of course, give xylazine. And dexmedetomidine is reliably reversed with antecedent. So receptors. So we administer dexmedetomidine, and it works on the CNS, and the binding leads to sedation and maybe adjunct analgesia. So and what I mean by that are the studies out there are a little bit conflicting. There is one human paper that showed that there was no opioid-sparing effect when patients were administered dexmedetomidine, but then there were some animal patient studies that showed that it did have an opioid-sparing effect, and it did have a effect on the thermal nociceptive testing that they were doing. So maybe, we just don't know. We do know that because opioids are sedative, that they will work synergistically. No matter what, they're going to work together. Causes muscle relaxation, and we have central mediated effects on heart rate and afterload. So side effects. So we've got a little bit more than the benzos, right? Patient selection is key in dexdomitor. So we have initially a dramatic increase in systemic vascular resistance. We have decreased cardiac output 30 to 50%. So you better make sure that your patient is able to handle that amount. Increased myocardial oxygen consumption. Cats are more likely to vomit with dexdomitor than dogs, and we get transient hypoinsulinemia and hyperglycemia. So we like to use high doses for sedation for even some procedures. I've done pin removals on dexdomitor and some really even complicated wounds. And also we combine it often with butorphanol or other PRMUs to lessen the dose or the adverse effects and augment analgesia. Does anyone's hospital carry both the concentrations of dexdomitor? Yes, a few. So how do you guys make sure that you get the right one? You're just super careful. That's kind of the way to do it, right? So it comes in two different concentrations. The 0.1 milligram per ml came out to be less concentrated, so we can actually have a higher volume instead of trying to measure a half a unit for that chihuahua that you get in. So that's why if you don't have it in your hospital, this is a really great concentration to get of dexdomitor, so you can get more accurate dosing and don't end up having to dilute it out. So some more notes. We want to use, this use is limited to healthy euvolemic patients due to those profound cardiovascular effects that I talked about. The dosing is based on body surface area. So the drug actually comes with a handout on how to actually dose it instead of in micrograms per kilograms. Patients will experience varying degrees of hypoventilation, but the risk is going to be increased if you combine it with, let's say, hydro versus butorphanol. And it's recommended if a patient turns apneic to intubate rather than reverse the drug. So what do I mean by that? Well, when dexdomitor became more popular, and in my surgery department they were using it so often, I would sometimes find myself, if we had a dog came in that was super painful with a fracture or needed total hip replacement or something, we would combine it with oxymorphone or hydro instead of butorphanol. And then all of a sudden, some of these patients started hypoventilating to the point where they were completely apneic. So then I would reverse the drug. But then I would have an animal that I still need to get TPLO rads on, who just received antecedent, and now I need to give something else. So in time, I learned that this definitely could happen if I combine a PRMU with dexdomitor, and I'd rather just intubate that patient and then even breathe with him with an ambu bag if I have it, if I don't have an anesthesia machine handy, and so I can still go on with whatever diagnostics or procedures I need to do. Does that make sense to everyone? Cool. Monitoring. So always flow by O2, that's for that increased myocardial oxygen consumption. Visually assessed ventilation, right, they're not intubated, so we can hook up capnography. And if you have an ECG available, definitely put it on. If you can't, just I intermittently palpate their pulse and give them a good listen. So dexdomitor is a biphasic drug. Has anyone ever heard this? Okay. So phase 1, this is where we have this dramatic increase in systemic vascular resistance, and because of that, a reflex bradycardia. What happens if the drug has not been reversed yet, around 30 to 45 minutes later, but that's dependent on the patient and their metabolism and clearance, all of a sudden we have that really high systemic vascular resistance returns to normal. But then we have that persistent bradycardia because of decreased sympathetic outflow. So then what then? Because there was all that controversy when dexdomitor came out that we cannot give anticholinergics, right? And there were a lot of patients actually arresting because of that when they were given atropine and given dexdomitor at the same time. In phase 2, you 100% can give an anticholinergic, and I do all the time. So the reason for this is because we don't all of a sudden have that increased systemic vascular resistance. I'm not worried about the patient getting any malignant arrhythmias. Their systemic vascular resistance is normal at this time, and this happens a lot when we pre-med animals with dexdomitor, and they're really out from it. And then maybe a half an hour into surgery, I have a hypotensive patient, and let's say I have a small dog with a heart rate of 60. At that point, I'm going to give glyco, and it's totally okay. Does everyone understand why physiologically? That's okay. Is that in contrast to what other people have been told? Okay, cool. So our dose, super complicated, right? Because it's based on body surface area, I don't know anyone who still goes by the insert in the package. We all do micrograms per kilogram. But there are some guidelines. So patients under 5 kilos, you definitely need a higher dose, mid-range dose. And then for large patients, I can get the same level of sedation, like in a 45-kilo dog with 3 mics per kg, as I can in, let's say, a little Yorkie at 15 mics per kg. That's what body surface area dosing means. And then dexdomitor CRIs, which are very lovely in the ICU. We want to err on the higher side of the dose if administering IM because it causes vasoconstriction, right? We want to err on the lower side of the dose if you're giving it IV or combining with a Pure-Immu. I could talk about dexdomitor forever, but we're going to go on to phenothiazide.